All right. Do you have a third case?
No.
All right. Does anyone have any other questions? Well, since we have time anyway, I will just say this is something that we have to discuss at least once or twice a year. And that is, as Dr. Rosen said, when we were young, it was malpractice to make a fan and steel for a stat C-section. And the people who trained me, that was their mentality. And I know that residents today do so many fan and steels and so few vertical skins that um, they feel that they could do a fan and steel faster because they're so practiced at it than they could do a vertical. And so that's why I just say to every resident, we're not going to solve this in a 5-minute discussion, but I say to every resident, take every opportunity you can to do a vertical skin. And while you're doing vertical skins, make sure you're thinking, okay, I always need to know this incision to save a life. If you have a woman who's coding or a trauma or something like that, you've got to be fast with your vertical. So I understand you do so many fan and steels that's where your comfort lies, and I don't disagree with that, but you have to cherish every vertical you can because you can save a life someday.
Dr. Ebert, I just want to add one more comment. I think we have a minute.
Yeah,
the
of
one
course.
thing also, yeah, the other thing, I mean, this wasn't a stat C section, that first one was, but when I trained, we were all trained to do exactly the same thing every time. And there was like only one way of doing things. We've all trained, like all your attendings have trained in different places, and we kind of all have our own way of doing things. But in the stat C section, I think you want a pretty coordinated and organized effort. So the way we did it back in my training, and I think it's still a very good way, like normally when you're going in, especially in a primary belly like we had on this last case, the first case today, somebody holds, like these main surgeon actually holds a Kelly clamp and the other operator has a knife, and neither of the two people ever let that instrument go. So you go through the knife, the surgeon goes through the knife. When they get to the fascia, they nick it on both sides, and let's say we're doing a stat fan steel or stat jolt cone, then you bluntly open up the fascia. That same operator, like with the Kelly, kind of palmed, opens up everything bluntly, tense up the vesicourethric peritoneum if you're going to do a bladder flap. The surgeon with the knife makes the cut. Then we bluntly create a bladder flap, throw in the Balfour, nick the uterus, bluntly extend that and get the baby out. But the surgeon never lets go of the knife, and everything else is done with the doctor, the other doc holding the Kelly. If you guys do that, it goes much faster. Like when our stat C session, because the other attending and I do things in different ways, there was like a lot of like, no, you do this, no, you do that, no, you do the other thing. But that's a really good way of doing it, and maybe practice that. One surgeon holding the Kelly, one surgeon holding the knife, and never letting go. And the doc with the knife pulls the blade away and out of the field when the other surgeon is doing the blunt dissection. I have not done that one with you guys here, but that was very effective. It was coordinated and it worked really well.
Yeah, if I could agree with Dr. Ebert. I mean, Dr. Rosen. That's the way I trained. One person holds a knife; it never goes down. That your assistant he or she is the dissector. That way, you move in tandem.
All right. Well, thank you for that. It's time to transition, though. Thank you, Viraj, for doing an excellent job. But it's time to get ready for Grand Round. So in just a minute, I'm going to ask Dr. Matthews to introduce our Grand Round speaker. But before that, if I could just make a comment or two about attendance. Someone is logged in as just simply iPhone, and we can't have that for both attendance reasons and for security reasons. So 2 people were logged in as iPhone, and I sent them a chat and they changed their name, which thank you very much. But one person is still logged in as iPhone, and we're not allowed to have that. So please, if you could just let me know who you are or change your name or something within the next 10 minutes. All right. And with that, Dr. Matthews, are you ready to introduce our speaker?
Yeah, I am. Good morning, everyone. Sorry, my allergies are acting up, so I might snuffle and all of that a little bit, sorry. But I'm very excited this morning to introduce our Grand Round speaker. I get very excited when I get to introduce people that have had some impact in my complex family planning life. And Dr. Jody Steinauer has had some impact in my life. During my fellowship time, she mentored me when I was doing my fellowship research. And so this is very exciting for her to come and speak to you guys and give you guys a little bit of her greatness. So I'm going to start off with introducing her. She is professor of clinical OBGYN and reproductive sciences at University of California in San Francisco. She stayed in California for all of her training and has gotten her MD all the way up to her PhD in California. She has expertise in health profession education and curriculum development and evaluation and faculty education, and understands that mentorship is important because she mentors a lot with students, residents, fellow, and junior faculty. She is the director for the Rhine Residency Training Program, which we have here, so you guys are very familiar with that. But the program, for those who are on the call that don't know, it's a program that really integrates family planning care in OBGYN residency training, which means that residents and medical students get to be trained in abortion and contraception work. And so she manages all of that. And in 2019, she was able to complete her PhD dealing with health profession education and training with a master's in research. So Jody has lots of expertise in education and curriculum development. And her talk today is really focused about what the impact is after Dobbs for training the next generation. So I'm excited to hear what this is going to be about, and really excited for you guys to get to know the person that I've come to respect greatly. Take it away, Jody.
Thank you, Glenmarie. It was such an honor to mentor you. You're just incredible, and I'm really proud of you starting a Ryan program and doing all that you do. So thank you, everyone, for inviting me to give Grand Rounds. I'm going to talk today about why we should care about training the next generation after Dobbs. And I'll start with this quote because this was based on work we've done to explore moral distress among OB/GYN residents in states with abortion bans. And this Texas OB/GYN resident said, "It's hard to describe the words that I feel. The complete sense of inability to care for people. We do the bare minimum of what we're allowed to do, but we can't actually care for patients when they need it because we're not allowed to. It's just this complete sense of worthlessness. It's so hard." And that really captures what many learners are experiencing throughout the country now that the Supreme Court decision, Dobbs, which was decided in 2022, allowing states to ban abortions, has done. So I have no disclosures, and these are the learning objectives for the talk today. We're going to review the history of abortion training in OBGYN. We're going to analyze the impacts of and justifications for abortion integration in medical education. And we're going to talk about the impacts of restrictions on learners. Let me just move my screen around. Okay, and on the workforce. So this is a map, which maybe many of you have seen. The Guttmacher Institute keeps track of the levels of bans in different states. And in this map, now they've changed their color coding system, but for the last many months, the most restrictive states are dark orange. And basically there are 12 states with complete abortion bans and an additional 4 states that have bans at 6 weeks of gestation. And now I'm going to show you the map with the number of OB/GYN residency programs in boxes, in squares in each state. And there are 52 OB/GYN residency programs in the states with complete bans, and an additional 28 in states with 6-week abortion bans. So there are about 1,700 OB/GYN residents training in those 2 categories of states. And as we'll talk about, it's very critical for OB/GYN residents to learn about abortion care. And so it's become a real crisis in how to make sure we train the OB-GYN workforce in abortion care. And as I'll talk about, that's not the only group of learners we should care about, but it is certainly one that's dear to all of our hearts. So why is it so important? I'll talk about why abortion access is important in just a couple slides, and then I'll focus the rest of my talk on training specifics. But there are about 1 million abortions in the US in 2023. And this is sort of a map of, or a graph of the number of abortions per year over time. And it had dropped to around 900,000 and then increased again after Dobbs to about 1 million abortions. The reason the line is not continuous is because in the pandemic, we didn't have good data for a couple of years. But just wanted to give you guys an update, which you might not know, that in 2023, 63% all of the abortions in the United States were medication abortions. And we continue to have very few abortions after the first trimester. We're now at about 93% occurring in the first 13 weeks of pregnancy. So we still have, second trimester abortions, but it is sort of the vast minority of cases. So already, and certainly before, so I always like to remind people that the Supreme Court Dobbs decision did not suddenly make abortion restricted in many states. But we have evidence before Dobbs and after Dobbs of some pretty problematic outcomes from abortion restrictions. There's now evidence of increased birth rates in states with the bans. Also, we know from before that there was already evidence of worse maternal mortality in states with bans. And since Dobbs, we now have a few studies that have documented increased neonatal mortality in states with bans. And part of it is just because, as you know, when we think about, it's obvious why birth rates have gone up. And we know that abortion is far, far safer than continuing a pregnancy to term, which explains in large part the maternal mortality increase. But this graph, or in a paper by de Klerk, shows that already even before Dobbs, states with more abortion restrictions, those are in orange, had fewer obstetric care providers than states without bans. So we also have what we often call maternity care deserts in these states with abortion bans. And also before Dobbs, we showed higher maternal mortality rates in these states, and of course, worse disparities. We know that Black women and Native American women have higher mortality rates in pregnancy. And you can see, again, this is the same paper. So the abortion restricted states are orange and the access states are in Black. So we see differences in maternal mortality overall and in all racial groups. There's an estimate that bans will lead to an increase in maternal mortality of 33% in Black women, 18% in Hispanic women, and 13% in white women. And sadly, that's beginning to be documented. So I hope you all, care about abortion being safe and accessible for patients. These are the three principles that was determined by about 200 international organizations in the profession of medicine. And they basically said that these are the three principles that are the foundation of the profession of medicine. The principle of putting the patient first, of patient autonomy, and social justice. And we have all these values. I'm just going to list a bunch. Mostly, I'm just trying to, as we think about abortion access, all of these are very relevant. So patient-centered care, values of equity, justice, beneficence, non-maleficence, quality and safety, and evidence-based medicine, and advocacy. So these are all values that you might hold. And a lot of times when I'm talking about the importance of abortion training, I just bring this up because it's sort of based on all of these values, we should care about abortion education and training. And, oh, sorry, I missed confidentiality. So OBGYN certainly must include abortion. Every OB-GYN must be able to counsel about and refer for abortion care, must have the skills to safely empty the uterus, care for people experiencing pregnancy loss, And both ACOG and our international organization, FIGO, say very clearly that every OB-GYN needs to provide abortion care in the setting of an emergency if they are the only ones who can. So because of this, abortion training is critical. And as I'll talk about in a little bit, it's really hard right now in many states. But let's just take a step back. Medical school must also include abortion. The goal of medical school is to improve the health of all people by preparing physicians to meet the health needs of a country's population. And abortion is part of healthcare. All physicians interact with people seeking abortion care. All must be able to counsel and refer, care for people after accessing abortion care, and uphold the professional obligations and values that I listed. And physicians in many specialties provide abortion care. And FIGO now has a clear statement with 2 international undergraduate medical education organizations that if you want to scan this QR code, you can read, very clearly stating that every medical school must include abortion. Our Association of Professors of Gynecology and Obstetrics has very clear competence requirements for all graduating medical students in the areas of abortion, so that all of our students should be able to provide non-directive counseling to patients. They should be able to list methods of abortion. They should be able to identify the rare complications of pregnancy termination, and they should be able to describe the public health impact of the legal status of abortion. And that's why many of us put a lot of energy into making sure that our medical students also learn about abortion. But so when we think about graduate medical education, we certainly think of especially 2 fellowships in which abortion is included. Of course, complex family planning, but also maternal fetal medicine. It really, by the last estimates, at least half of MFM fellowships include abortion training. It's very critical for, of course, our MFM colleagues to be competent in counseling and these skills. Family medicine it's solidly within the scope of family medicine, 41 programs, which I know is a very small proportion of programs in the country, but 41 programs do have integrated opt-out training. And there are a number of organizations that exist to support family medicine training. And one that I'll just call out is TEACH, Training in Early Abortion for Comprehensive Healthcare. This is an organization that has incredible curriculum on their websites for teaching primarily first trimester abortion care and also some second trimester abortion content too. And there's increasing training in internal medicine, pediatrics, and emergency medicine. And actually, in terms of education, there are some real positive impacts of Dobbs. And I would say the move within different specialties to care about abortion access and training, and then to integrate abortion training has really changed. And I'll just show you some of the papers that have been published. So there's been papers published about the importance of medication abortion in internal medicine. There's calls to action in specialties like pediatrics and attempts to integrate abortion, especially medication abortion, into pediatrics training. And I've done a lot of talks for our pediatric residents. Now the pediatricians do it, but they've completely integrated medication abortion in their training. And then emergency medicine is really transforming. I mean, they have such an important role with providing confidential care to people in emergency room settings, but more and more emergency medicine residents are even learning how to provide medication abortion for patients in whom they diagnose pregnancy and who don't want to be pregnant. In California, there are a few emergency medicine programs that just provide this care without consulting any gynecologists. We also should think about training beyond medicine. So these are all parts of our workforce that need to learn about abortion. And of course, advanced practice clinicians can provide abortion care in many states. And so we should think about training them too. So going back to OB-GYN, that's kind of what I'm going to focus most of the rest of my talk on. So we already talked through the basic skills that all OB-GYN residents must include. And I thought I'd just talk a little bit about the history of OB-GYN training. And I heard from your M&M discussion that many of you trained in the same era I did. So when I started medical school in 1992, there was a study that was published by McKay that found or a study that had been done in 92 that found that the proportion of OB-GYN programs that had routinely included abortion had fallen from 23% in 85 to only 12% in 92. And this, in addition, in combination with lots of other events at the time, really motivated different groups of people to care. So my mentors, Phil Darney, and many OB-GYN faculty members wrote pieces like these. Phil wrote a piece called "Who Will Do the Abortions?" And there was a real worry that this generation of physicians were sort of thinking about retirement and who would be the people who would take over comprehensive reproductive health care after they had retired. A bunch of us were organizing from the medical student level, with Medical Students for Choice being founded, thinking about how we could advocate for curriculum change. And also ACOG was very much involved in thinking about this, along with the abortion providing community. And basically all of these sort of combined so that the ACGME implemented the requirement for routine abortion training. And it is the only specialty that has this requirement. So family medicine does not have a similar requirement, but is now thinking about it. There's a lot of discussions in the national family medicine communities to think about a requirement, but we've had it since then. And as I'll show you, even post-Dobbs, the ACGME has confirmed their requirement for abortion training. Soon after the ACGME requirement was enacted, Dr. Ujalandi here at UCSF, who was also my mentor, established the Ryan Residency Training Program. And as Glenn Marie mentioned, this is a program that since then has supported OB-GYN programs to integrate care and training. After the ACGME requirement was enacted, many chairs and residency program directors needed help. They were like, well, okay, we get that this is important, but we maybe don't provide comprehensive abortion care in our hospitals, or we don't have relationships with clinics in the community that do. So the Ryan program began and still does provide technical support, and really has created a national community of educators who really care about abortion training. At this point in time, we've supported 118 programs to integrate training, which accounts for about 40% of all the US OB-GYN residency programs, and many thousands of residents have been trained in these programs. This is a map showing in blue the states that have at least one Ryan residency training program. And then the states with stripes are places that don't have an OB-GYN program at all. And so we only have a few states, 5 states in the dark gray, that don't actually have a Ryan program. You'll notice that some states are blue without the yellow dots, and those are states where there are Ryan programs, but they are not publicly listed as Ryan programs. So we do have Ryan programs in states like Texas, but they can't be publicly listed. After the ACGME requirement was enacted and the Ryan program began helping programs, we've had a few studies looking at the proportion with routine training. So remember, I told you in 1992, it fell to the nadir of 12%. And before Dobbs, it was pretty high. It was up to about 72% of residency program directors saying that their training was routine, meaning that individual residents could opt out of it, but it was part of the scheduled rotations. And only 8% were completely not available. There were about 20% with what we call optional training, and then that's where a resident has to opt into training. And in the last study in 2020, we did that survey at the time of the resident CREOG exam. We also asked one nuance, which will become important in a couple slides. For those with optional training, from the resident's perspective, is there a clear process for training, or it's not clear? And so, some programs will be very clear, like you can opt in and this is the place where you go. It's very easy to arrange. And some will be like, oh, sure, you can do it, but we don't really have a system for setting it up. And those, it turns out to be are very different experiences. So I'm just going to tell you a little bit about the perspectives of program directors and residents around how they feel about the training and what they learn. So this in the darker color is residents and the lighter color is directors. And this is just based on a question of how satisfied are you with the training? And what we have found is that the level of satisfaction with the training is highest in routine programs, and then it goes down to the optional with a clear process, the optional with no process, and none. And you can see that in general, the optional with no process is pretty similar to no training. It's not that different. So you can see it sort of correlates, negative correlation with integration of training. This is from the residents' perspective. This was looking at the subset of 883 chief residents about how confident, whether they feel that they were ready for independent practice in early pregnancy loss counseling, medical management of pregnancy loss, the two different methods of uterine aspiration, and management of complications. And you can see that they felt more confident for independent practice in all of these areas in routine training. This is a similar analysis, but a little more, you can see that these are different kinds of abortion care skills. So abortion counseling, medication abortion, the different methods of uterine aspiration, and management of abortion complications. And again, routine training, even though it's not at 100%, you'll notice, but this is sort of looking at these different skills. How can we train our residents in these skills? And they feel more ready for independent practice with routine training. Now, this is the program director perspective. This was asked a little bit differently. This was whether they felt that most of their graduating residents were ready for independent practice. And we grouped together all of those skills I just described. So in other words, to feel that their residents were ready for independent practice, in pregnancy loss care, they had to say yes to all of those skills I just mentioned, from counseling, the different methods, and management of complications. And again, you can see pregnancy loss care, second trimester care, first trimester care, and second trimester care correlated by routine, optional, and no training. So lots of important skills that people learn in training, in addition to sort of the values-based reasons why we need to train them. Okay, so that's my introduction to why it's important and how we should think about it. And now let's talk about post-Dobbs and about the challenges that we're facing in making sure that medical students and residents and even fellows get trained. Well, the ACGME has continued to uphold the requirement that abortion training needs to be integrated. The revised requirements say that programs must provide clinical experience or access to clinical experience in the provision of abortion as part of the planned curriculum. If a program is in a jurisdiction where resident access is unlawful, the program must provide access to the clinical experience in a different jurisdiction where it is lawful. And they also say that the programs have to support resident travel. So basically, they're basically saying that you need to do everything you can in your home program and also make a clinical experience available in a different state. This is just to remind me to say that there are a lot more family medicine programs than OB-GYN programs. So the map on the left is from a paper we published before, right when Dobbs was being decided. And this was a map showing states in which abortion was likely to be overturned. And each of these dots is a residency program. And the one on the right is family medicine programs. This paper was published a little later. And I know the dots are different sizes, et cetera, but you can just see that there are about twice as many family medicine residency programs. So as I mentioned, there are about almost 2,000 OB-GYN residents training in states with bans now. Well, there are closer to 4,000 family medicine residents training in these bans. And there are more than 20,000 medical students training in states with bans. And so we really have a puzzle before us of how to make sure all of these learners are getting exposed to abortion care. I now want to just shift for a second and talk about the impacts of Dobbs on the workforce. So I'm going to show you a series of slides that are published by the AAMC. And what each of these shows, so this is in general medical student applications to all specialties. And it's organized from left to right with these little colors to all states, to states in which abortion is banned, to states with gestational limits, and where abortion's legal on the right. And what the AMC does is they track the change from the previous year. So I just want to draw your attention in this case to starting in 2022, they noticed right after Dobbs that there was a different decrease. There was overall fewer people applying to residency in all states, But you can see in general from all states, 1.8% fewer, but they noticed that states with abortion bans, it was 3.3% fewer. And then even compared to 2022 to 23, there was a further decrease in the next year. So why is this that there was a difference compared to previous years? And, a lot of people have written about this. There have been a few exploratory studies trying to understand the impacts of Dobbs in general, not just on whether or not you are going to provide care for people who might need abortion. So for one thing, there have been a few papers like these on the left. The top one was the impact of Dobbs on decision-making among urology applicants. And then here's one on cardiothoracic surgery training. And basically, different specialties have written about concerns that people will choose to not do training in their areas in banned states because of the person or their partner's personal family plans. So worry that they would be in a state and then would become pregnant, and then something could happen and they wouldn't be able to get the care they need. There's also been a few studies trying to understand from the medical student's perspective of how they're making decisions. And, all of these studies sort of say similar findings, that there are concerns about the care they can provide to patients and the care they might receive for themselves or their partners or other family members. And I thought I would just show you the paper on the bottom right is by Bernstein and Levy. And this was a study of practicing physicians on the top bar, resident physicians on the middle, and medical students. And the question that this graph answers is, why will the overturning of Roe v. Wade affect your decision about where to apply or where to go to the next step in their career? A small proportion did say it was because of their own intentions to provide abortion care. But then there's access to abortion care for my patients, access to abortion care for myself or my partner, access to abortion care for a family member. And you can see that one particularly was the largest proportion was practicing physicians. And they also explored the qualitative open answers to open-ended questions. And a lot of these people said, I have teenage daughters. What would happen if I were in a banned state and something happened to them where they needed abortion care? And then if for a small proportion, it wasn't affecting their decision at all. So we have a lot of sort of explanatory studies of trying to understand the reasons, but now I'm just going to show you specifics. So here's medical student applications to OB-GYN. It's probably not a surprise that had a much bigger impact in terms of fewer people applying to states with bans. With a drop in 11.7% of people who applied to at least one program in a banned state. So it was a big difference, and a further decrease in the next year. What kind of surprised me is they just came out with their 2023-24 data. Well, before I say that, family medicine, you can also see they kind of predated. They had a change even before Dobbs, 21 to 22. Now, remember, SB 8 had passed in Texas already, so we all kind of knew it was coming. But family medicine sort of changed their behavior, their applicants first. But look what happened in 23-24. All of a sudden, emergency medicine applications dropped in banned states. Pediatric applications dropped more in banned states, and internal medicine dropped more in banned states. So it does seem like people are starting to worry about their ability to provide care for their patients, even if they're not planning to provide abortion care themselves. They're worried about not being able to meet standard of care for counseling and referral and other things. We have a little bit of data about what happens after residency. This was just a simple, beautiful study of final year residents, and found that about 18% had changed their planned state of practice after Dobbs. Of those who changed, 78% had originally intended to practice in a restrictive state and changed to wanting to only practice in an unrestricted, and about 22% had changed in the opposite direction. And so we do think that this is going to change. There have been a couple studies trying to map migration of physicians based on Medicaid registrations and other kinds of large databases, and so far haven't really found a huge migration, but different groups are sort of monitoring that to see. And we know it's complicated, the reasons why people leave or stay in different states. I have to say that anecdotally, I've met, and Glenn Marie probably has too, a lot of people who are also motivated to practice in restricted states, and actually are just like these people who care so much about providing the best care they can that they're even actively pursuing jobs in restricted states. So I don't think it's going to be completely clear that there is sort of any migration out of banned states, but people worry that the net effect will be that we'll even worsen these maternity and reproductive healthcare deserts in states with bans. So what are we all doing? There's a lot of efforts nationally. There's this group effort between CREOG, we at the Ryan Program, and Innovating Education and Reproductive Health to create a standardized curricula for all residents called PACE, Patient-Centered Abortion Care Education. And there's a lot of groups working on simulations. You can go onto the Ryan Program website. We've collected a nice group of first trimester and second trimester simulations. There are also groups working on counseling simulations. There's a lot of online teaching about medication abortion. So we have a lot of available curricula to try to maximize as much as possible. The problem with just focusing on didactic knowledge is it's one thing to learn the information and just have the knowledge, but it's a very different thing to apply the knowledge. And we just had a meeting a few days ago in Texas with many program directors in Texas. And what we heard was that they're all working hard to make sure everyone can learn the information, but then without seeing it and interacting with abortion care regularly, they don't necessarily apply the knowledge. And so it's not necessarily sticking. These are all programs that have out-of-state training, which I'll show you sort of that landscape soon. But I do think it's a challenge that the knowledge itself isn't quite enough. So what's going on with out-of-state travel? Well, beginning after SB 8, we and lots of others have been trying to support first programs in Texas and then around the country. In the pre-Dobbs days, there were lots of groups that tried to make training available for individual residents. But as soon as SB 8 happened in Texas, we realized that it was like a lot of work for one resident. And so we started establishing partnerships between programs in banned states and programs in unrestricted states. And I know you guys are working to create a partnership with a program in Florida. And these partnerships take a long time to set up. And so there's all these steps. So first the program identifies the need, and then we begin trying to figure out, well, how many residents need to be trained? What year of residence? How long is the rotation? When can they go? And then we have to find a partner, a host institution that could accommodate them. And then there's all these legal arrangements that have to be in place. And then, all kinds of stuff, from program agreements to state insurance issues and all these different things. And then there's the individual residents have to jump through a bunch of hoops, as you know. And we found from starting by helping the programs in Texas that it takes about 9 months from beginning to actually the resident traveling. So it takes a very long time. So I just wanted to show you, pre-Dobbs, there were 2 states in which residents had to travel for training. And these were Ryan programs that traveled out of state. But I'm just going to show you quickly what it looks like since. And so we've had a lot of partnerships that started and then ended and all these things. In these maps that I'm going to show you, each arrow is a program to program partnership. It's not an individual resident traveling, it's a partnership. So right after SB 8, we supported 5 programs right away to travel out of state. And this is kind of where they traveled. And this is what has happened since. So we set up these programs. And then we had travel between these states. And then we started supporting the first program in Florida. Oh, now Tennessee needed to change their rotation. Oh, now we have a lot more Florida programs, especially with the 6-week ban that need to be trained. And now we have, it sort of looks like this now. So that sort of gives you the current landscape. So we've supported about 20 programs. Also, Oregon Health Sciences University has been really supportive of individual residents. So if you know of places where the program isn't quite able yet to have a partnership with an out-of-state site, But they have individual residents who want to travel out of state. They can apply through the Oregon Health Sciences University program to go there. And what's happening is now they have such a high demand, they can't meet everyone's needs. And then they send them to the Ryan program, and we try to help at least an individual resident travel. So we're really trying to support programs and individuals. We also have done this project called Abortion Training Nexus, where we've interviewed over 70 stakeholders in the travel landscape. And this is directed by Dr. Chris Brandy. She works with us on it. And what we've found is that all of these stakeholders, sending faculty, receiving faculty, I shouldn't say just faculty and staff, learners, and also clinics really need more support to support this whole travel landscape. So we're in the process of developing lots of tools. I'll just give you an example. Busy clinics that are providing abortion care and whose mission is to really provide care can be intimidated and a little overwhelmed by hosting learners. And it also feels to them like, you know, they worry that if they have learners that they're not going to be able to provide either as high of quality of care for their patients, or just to meet the need, the sheer volume of patients who need to be traveling to see them. And so they really asked for tools like some things that might seem basic to us as educators, because we're doing it all the time, but like, how do we orient learners? How do we figure out what their learning goals are? How do we assess them? How do we give them feedback? So all these things that we kind of do all the time, the clinics are really asking for. And so that's an example of tools we're developing for clinics themselves, but also just anything we can do to streamline all the legal requirements, et cetera. And so now, then the last topic I want to talk about before we open it up for questions is moral distress. So moral distress is basically the experience of emotional distress when you are unable to provide care that you think is the right care, or that you're forced to provide problematic care because of a policy. And, learners and clinicians are witnessing inequitable and unsafe patient care. What we've found in this qualitative study of residents is that it's a little, it's similar to what we know from other studies about practicing clinicians. But what we found is that watching this inequitable and unsafe care and feeling that they're participating in it is also challenging because of their identities as new physicians and as people who are developing their identities as OBGYNs. So this is the quote I read at the beginning. And basically, we published this paper that just describes sort of how it interacts with their identities and what's so hard about it for them. And then we also asked them to talk about the strategies that they're using and that they're seeing. And so I wanted to talk a little bit more about that. Oh, and before I say that, I'll say that despite their moral distress, these residents are so committed to providing the best care they can. And this resident from South Carolina said, "I feel like I'm willing to jump through hoops to help patients get the care that they deserve because I believe so deeply in their right to have that care." What we found in the strategies analysis is that they use all these strategies to manage their moral distress. And by the way, some people use the term moral injury, which technically is sort of a long-term impact of having moral distress for a period of time. And so it's thought of moral distress as like the feeling in the moment, and moral injury is sort of long-term harm to someone's sort of emotional state. So of course, a lot of these people are experiencing moral injury as well. So these are the strategies that the residents described using and seeing: maximizing clinical care, different techniques for supplementing their education, engaging and watching faculty engage in advocacy, and sort of obtaining emotional support. So I'm just going to share some quotes, because what we found is that for each of these, they talked about examples that were helpful for their moral distress, and then they also talked about some negative impacts of some of the strategies too. So in terms of maximizing clinical care, this is like a pretty typical quote. This resident said, "Well, I'm more willing to help patients find workarounds for a current system, providing them online resources that can help them figure out how to get an abortion in this state, or pointing them towards So being more willing to be a little bit less conventional and think outside of the box to help patients get access to the care they want. So many residents talked about spending more time with patients, going out of their way to find access, to help them get out of state to a clinic or to access medication abortion online, et cetera. But of course, the negative of that is just, it's totally exhausting and feeling like they are just burning out because they're working so hard with these patients. And this is another example of kind of the negative side. This resident said, providing extra help to patients almost feels secretive, and it shouldn't be. We don't believe that abortion is a shady deal, right? But we're almost forced to be shady. And then that plays into the narrative that abortion is a shady kind of thing. So this sort of like secret time spent in clinic, secretly giving information about where to access online, even though the residents felt like it helped them, like they felt like they were finally able to do something to help the patients, which helped them, you know, emotionally, but it also felt like it was contributing to stigma. In terms of supplementing education, a lot of people talked about travel. So not all the residents were in programs with travel arrangements, but some were. And so this resident said, out-of-state training helped a lot. It just made me able to do something where I was at least out of my class. We got 7 physicians now who can provide this. We organized and we made sure that we were able to get this training. And here's sort of the flip side. The residents and faculty at the out-of-state training site don't get it. Like they have no idea what it's like to have your patients not be able to get care. It's just like such complete opposite sides of training. Like one place having the easiest access to care you can imagine, and then going in between there to like Texas with the most restrictions on women's care you can imagine. And I think that's it. It ends up being really hard for our residents to come back to this after seeing how easy it can be. And this is something we heard from the very beginning, that residents would go to a place where it was so easy, where it was just like, I'll give you an example. There's a Texas program, many Texas programs go to programs, to residency programs in Southern California. And they just cannot believe how like there's no waiting period. There's not all these hoops that people have to jump through. It's just part of care. And then they come back to Texas and they're really sad. It's just so hard and stigmatized and uncomfortable. And then they even have patients with like PPROM and they can't do the right thing for them. And so that's kind of shocking. So that's something that a lot of these sending programs are working out, is how to provide the support when the residents get back. All right, what about advocacy? Well, a lot of people talked about how great it was to participate in advocacy efforts. One said, I've been involved with local rallies to support abortion rights. I would say that that does allow me to feel like there's at least something proactive that I'm doing. It does help mitigate those feelings a little bit. And then this other resident, just the flip side of that is, I've written some emails and letters to my state representatives, which felt somewhat helpful, although also feels like screaming into the void sometimes. So this sense of like, is this really helping anything? They also talked a lot about how great it was to watch their faculty advocate, not just like on a state level, but in their hospital. And so I remember one quote that I really liked, which was, she was describing an MFM faculty member who would advocate so hard to get individual patients the right care that they needed. And it was very important for them to see us role model advocacy. And finally, just ways that they found emotional support. One said, the attendings that we work with they're very supportive. They're very consistent about taking the time or the space to speak with you or help you answer questions or challenges. They spearhead a lot of the institutional changes that we've had, so they're very involved in everything. And here's like another kind of a negative on the same theme. It's frustrating and we talk about it, but like talking about it doesn't help because it's a situation we're in. Like, or we continue. It's been a year and a half or however long now. Nothing's better. Things are worse. And talking about it honestly, it makes it worse, I think. So some people felt like talking wasn't helpful. Some people felt like it was really helpful. Some described facilitated discussions, more formal opportunities for reflections. And some talked about like this first quote of just how it was helpful just to do one-on-one and to hear from us that we were also experiencing moral distress. So, one of the next steps from this work is to try to work with programs in these restricted states to think about how to apply what we learned and thinking about ways that they can help residents mitigate their moral distress with these different areas. Like, could they provide more time in the schedule for patients, for longer patient conversations. Residents ask for things like clarity around policies, especially the policies that come up are around who does qualify for a legal abortion. Does a PPROM patient have to have an elevated white count or fever? Do they have to have signs of infection before they can do anything? Which medical circumstances qualify, et cetera. And so that can be really confusing for them. So things like ways that they can supplement their education, engage in advocacy, and how can we support them by supporting reflection? All right, well, I'm just going to close now and open it up for questions. But what I would ask, I hope that you're inspired to care about this and to think about ways to support all learners in the health professions workforce to learn about and even be trained in abortion care. I hope you'll be inspired to collaborate across disciplines and think about your nursing learners as well as other medical specialties. And I'd love to hear more about what you guys are doing in that area. Support organizations that support training, and to really think about advocating for safe legal abortion everywhere. Also, I wanted to make sure you know about Care Post Row, which is it's a website based here at UCSF with the Answer program, where if you interact with a patient whose care was affected by restrictive abortion laws, you can actually write about it on their website. And then you can also volunteer to be interviewed about it. I provide care. Also, I do abortion care. Well, I do comprehensive. I do full OB and GYN still at UCSF, based at San Francisco General Hospital. But I also travel to Wichita, Kansas, where I provide abortion care at Trust Women Clinic. And so I've had many experiences of patients who really should have been able to get the care they needed. Most of our patients travel to Kansas from Texas. And so I've had the chance to go and describe some of the ways care has been impacted by abortion restrictions there. So thank you for your attention, and I'm happy to answer any questions and hear about your ideas.
Thank you, Dr. Steinauer. Thank you so much. Are there any questions?
I also want to say there was just a paper published about moral distress among maternal fetal medicine fellows, which was super interesting. They asked about all these different sort of abortion-related care scenarios and asked the level of moral distress that they're experiencing. And they found that MFM fellows in states with abortion bans are experiencing a lot of moral distress.
Thank you for the article about obstetrical care after uterine perforation. I screenshotted it, and I'm going to look it up and send it to all the residents when I get a chance. I see that Dr. Bayat has her hand up.
Hi, good morning.
Hi,
I'm driving, so I hope that you can hear me. Okay, thank you so much for such a wonderful talk and for everything you've done for our family planning academic community. It's sincerely appreciated. I was hoping to hear your thoughts on, I guess something I keep thinking about is whether or not training programs in states that have protected access to abortion, whether we need to somehow be more thoughtful or deliberate about recruiting residents who will provide abortion care. So I think a lot of times, like we have, if there's a spot in a state that has abortion training and that person will not be providing abortion care because of their personal preferences or beliefs or whatever, that kind of breaks my heart because I feel like it's a lost opportunity. And I'm just wondering what your thoughts are, because I know we can't screen people out based on that and discriminate, based on that. But I was just hoping to hear your thoughts and feelings about that.
Yeah. I don't totally agree with that, because here's my take is that every single OB/GYN resident needs to learn about abortion. And I have there was a period of time when programs would have abortion training scheduled, and individual residents, if they didn't want to fully participate in abortion training, they would just completely opt out. And so we started studying people who said, I am planning to not do abortions after residency, but who went to an abortion care setting and learned about it. They learned all these transferable skills. They learned how to do ultrasound, how to counsel. They saw abortions. They did abortions. Sometimes they did some abortions to learn the skills. Sometimes they only did procedures or medication management for miscarriage. But it transformed people's feelings and attitudes about abortion care, had such a positive impact. Many went on to say, you know what, I'm gonna sort of change my intentions. And I had come to this with these ideas and sort of an intention to not do abortions at all. Some people said, I'm going to start doing it for these circumstances. And it's so important to expose people. Some people did still plan to not do abortions, but they were supportive of their colleagues who provide abortions. They made sure that people got the care they needed. So basically, it's a really important opportunity for everyone, I feel like. There's a theory in medical education called transformational learning. And transformational learning is when you are it happens when you're faced with something that sort of deeply jolts you and challenges your beliefs. And often it's when you're faced with something that is very disconcerting to you. Like if you really personally felt that abortion was immoral, really grappled with that. And then you happen, let's say you're a student, and then you got to spend a day with Glenn Marie or Lily providing this incredible care. And you were like, oh my God, they're so kind and respectful of patients. I had this idea that people who provide abortion care are not competent, whatever your ideas were. And you got to watch them and how kind they are and respectful and supportive. And then maybe you even saw that they counseled some women who had come to the abortion clinic and the patients had changed their mind and decided they didn't want an abortion. And that was like surprising to you, whatever your preconceived notions are, that it changes your idea. And that is when transformational learning happens, when it sort of requires something shocking or surprising, and it can really transform how you feel about this. So my take is that we should be training everyone and giving everyone a chance. I mean, we at UCSF, though, we've had abortion training for 30 plus years. We train our residents up to 24 weeks, D&E procedures, we do all that. And so we're really clear when people interview that this is the training we offer. And we really encourage people to rank us highly if you want to take advantage of that training. But I do think that we have really welcomed everyone, even our residents who have only wanted to learn first trimester procedures, and even our residents who have partially participated. So I don't know. I hope that answers your question, Lily.
I see that Dr. Matthews has her hand up.
Jody, thank you for a very informative talk, and it's just packed with information and has my mind rattling around lots of ideas because I am an idea churner and how to activate my ideas. And I wanted to give you some background on our practice here, and because you asked about that. So in the state of New Jersey, we do have mid-level providers that are being trained in abortion care, and in our clinical setting, we have mid-level providers that work with us and that are being trained also in abortion care, counseling, and providing those services. We also are going to start taking mid-level providers, students that are going to come with us in our clinics and learn how to provide abortion care. Within our program, I'm trying to get everybody on this call to remember that we have MBAs in the ED, wink, wink. And Dr. Bide are always available to be there for your first go around, and then you can just be the superstar that you are and do it on your own after that. And here we go up to 26 weeks because the state of New Jersey does not have a gestational age limit. And at our program, we have the privilege of going up to 26 weeks and 7 days. So we are in a good place. We're working with a program in Florida to also accept trainees to come in. So we're kind of, Kristen and I are kind of on that map in that Florida.
Yeah, you are.
To New Jersey situation.
We need that arrow on my map.
To try and make it happen. But I guess I have a question, and I guess my question is, how is the Ryan program going in the states that already have protective, how is the Ryan program going to those different hospital and institutions to really get them to understand the need to incorporate this erroring situation, I'm going to call it, this relationship with different programs throughout the United States? Because I feel like it's something that is a bigger need, and we really need to make this happen more.
Yeah, I mean, this is the big crisis. We've got 20 arrows, so we have 20 partnerships created, and there's at least 60 programs that need it. And so we're just still very early on in the process. I mean, one thing we've been doing is, you saw in my graph that we'd only gotten to 72% of programs with routine training. So we were not there. We just had an in-person meeting with programs in Michigan, for example. And, it's like 12 programs from Michigan at the meeting. And there were only a few where they really had fully integrated manual aspiration in the emergency room, truly patient-centered pregnancy loss care, mifepristone on formulary, D&E services, induction terminate, and so I think you're right. We're spending, in some ways, even more time on the permissive state programs to make sure they are doing everything they can to provide care. I mean, you're a model because you're also training you're going beyond OB-GYN and training your advanced practice clinicians. So I think there's also training locally is super important. Like, I'm also trying not to just be only like, you need to take someone from out of state. You need to make sure that everyone in your community is getting access to training. And then if you have openings, please consider taking someone from out of state too. So you're exactly right. I mean, there is so much work to be done in the unrestricted or less restricted states as well. And so we've created one post-Dobbs positive effect was the way that communities have come together. So the Iowa programs are really organized. The Indiana programs are organized. The Florida programs are organized. The Texas programs are organized. The Michigan programs, whereas before they were kind of like mildly friendly to each other, but also a little bit of a competitive feeling, especially in the same cities, two different hospital systems. And so we're really building community to try to improve care in all these places. And absolutely, the unrestricted states need to be providing care to every single patient who needs it, and of course the restrictive states also need to really expand, make sure that they're providing it for everyone who qualifies.
Okay, my last question before Jaron. So with that being said, burnout, or I don't want to call it burnout, but I just want to call it overextension of myself and invading some of my personal time with people I love. And so are there resources for people that are in states like New Jersey, states like California, where we're out here hustling, and I will go in on a Saturday to watch somebody do an MBA because I'm crazy like that. But are there resources for people when they feel like their cup is really getting a little too full and it's not half empty? What resources are there for people like that?
Well, for you should call me and we should have a conversation.
Of course.
I'll be your resource. That's a good point. I mean, we mostly just sort of encourage people to create their support systems with each other. We've definitely advocated for hiring additional people so that there's not one person covering all the time or two people covering everything. I was at one program in Tennessee where the residents were so upset by how hard their two family planning people were working that the residents wrote a letter to the chair and asked for raises for both of those people and got them. So anyway, I don't know if money would make a difference, but there would be that.
All right, well, with just 2 minutes left, I see that Dr. Sadeghi has their hand up.
Hi, I'm one of the PGY ones. Thank you for this talk.
You're welcome. Yeah, great.
I have a question for you, and I was curious if, given the the hostile political climate as it is, and as it's become, if you have a kind of frank forecast for what we can expect out of abortion care in this country, say like 20, 30 years down the line. I'm just curious because I personally, given what we have and what we're faced with, feel pretty snowblind. And so I was wondering if you have any insight.
Well, I am generally optimistic as a human being. It's really hard right now. I feel like for abortion, people are voting to support abortion access. So I really feel optimistic because of the grassroots efforts. I mean, I know that states are now trying to make it really hard for individuals to pass ballot initiatives, but I really like Missouri is an amazing example. Missouri had no abortion clinics long before Dobbs. And the Missouri voters said, nope, that's not okay. We want to have abortion access in the state of Missouri. And so they just started doing the first abortions again after years and years of no abortions in Missouri. So I feel like for abortion, I think things are going to get better. I'm currently really, I mean, most of my patients are immigrants, and often they are not, you know, they have no documentation. I'm very worried about immigrant rights and trans and gender non-binary rights and like DEI efforts. So there's so many other things right now that I'm feeling pretty worried about. For some reason, I feel like abortion is going to be fine. I don't know. Glenn Marie, do you have a closing thought on that? How are you feeling about abortion rights?
Why are you pulling me into this last closing line? It's 9 a.m. I just want
Okay,
to
fine.
We got to keep fighting, be optimistic, and we got this.
Exactly. Yeah, I wanted you to do the closing words. Thank you.
All right. Well, Dr. Steinauer, thank you so much for this.
Thank you
great talk.
all.
Thank you.
All right. So we're going to have to end it here. I hope everyone has a safe and successful day.
Thanks.